So it's a pleasure to invite Dr. Jun Kong to speak to us on the benefits and limits of geographic atrophy treatments. Dr. Jun Kong.
And that's going to be a pre-recorded
It's a
presentation.
pre-recorded presentation. Can we have her presentation on, please?
I'm Neil Bressler, and I look forward to presenting the benefits.
That's not the correct one.
Not
geographic atrophy treatments in 2025.
Okay, I guess Neil's going to
I'm
give.
presenting this with my faculty colleague, Dr. Jun Kong. I'm happy to announce that Dr. Kong joined our full-time faculty on the tenure track at Johns Hopkins University School of Medicine just last week on April 1, 2025, and we look forward to our further collaborations with her both here and with her connections throughout Asia. These are my financial and other disclosures. Dr. Kong has no other financial disclosures. This is a typical example of a patient who develops geographic atrophy. Typically, they are in their 80s or 90s. They may have 20/20 vision, as this patient had in 2009. 4 years later, the central visual acuity on the eye chart still measures at 20/20, but the patient notices some pericentral scotomas that begin to interfere with reading very fine print. Another 3 years later, 7 years after the initial presentation, the patient remains 20/20, but more geographic atrophy can be seen when we obtain an OCT and we get this infrared imaging, which is a very good way of looking at it, at least as good, if not better, than having the autofluorescence or other ways of analyzing geographic atrophy. 10 years after first presenting, now the patient notices some central visual acuity loss in addition, down to 20/40, a 3-line loss, and more geographic atrophy involving the central macula. The growth rate typically is about 2 millimeters squared per year, and that's what you're looking at here. So there was general excitement when the FDA approved pegcetacoplan in February of 2023 for the treatment of geographic atrophy based on several randomized clinical trials. And then in August of 2023, avacincaptad was approved by the US FDA as well based on the clinical trials of GATHER1 and GATHER2. And yet, just a few months later, the European Medicines Agency recommended refusing market authorization for pegcetacoplan for the treatment of geographic atrophy. This was reevaluated, and again in June of 2024, the AMA again refused marketing authorization based on all the available data that they had at that time. They noted that it slowed the growth of geographic atrophy lesions, but the amount of slowing of the growth was not associated with any clinically meaningful benefits for patients' everyday functioning. And there was a safety problem. There was a significant risk of adverse events in terms of developing choroidal neovascularization and rarely some eye inflammation. And so they concluded they could not establish a positive balance of benefits outweighing risks and therefore refused market authorization. Now, since then, it has been approved in a few other places in the world, including Australia, but not everywhere. Limitation number 1, there was a lot of loss to follow-up. If we look at the patients that were assigned to pegcetacoplan monthly, more than 30% in one of the 2 trials and 29% in the other trial had loss to follow-up at the 24-month visit. We don't know what happened to those patients, and we can do all sorts of statistical analyses to try to impute for their missing visits, but nevertheless, our confidence is diminished the more and more people don't return for follow-up. Limitation number 2, the difference in the growth is actually minimal. Yes, you may hear that there was a 20% reduction with every other month therapy and maybe slightly greater with monthly therapy of pegcetacoplan. Yes, that's a relative growth that was reduced by 20%. But what's the absolute reduction? It's very small here. If you look across to the y-axis, at 1 year, it's the difference between 1.5 and 1.75 of growth of millimeters squared of geographic atrophy. If we look at 2 years, the control group's about 4 millimeters and the treatment group is about 3¼ millimeters squared. What does that mean? Does that make a difference at 1 or 2 years? If these patients are in their 60s, 70s, 80s, or 90s, will that make a difference over 10 years? We don't know if the therapy will continue to have this difference, but the magnitude I want to emphasize to you is very small. What's 3/4 of a millimeter squared? If we look in detail at 1 year, the absolute difference from this relative decrease of 21% was 0.4 millimeters squared between the control group, the sham group, and the pegcetacoplan group. And there's a confidence interval around that. That's just the point estimate. The real answer is somewhere between 0.64 and 0.18. If we look every other month, it's even less. It's 0.32. And the confidence interval is somewhere between 0.54 and actually plus 0.9. It shouldn't be minus, it should be plus 0.9. The 2-year outcome, the absolute difference is 0.63 to 0.9 squared, depending on the trial. What does this translate to? What's 1 millimeter square of growth? This slide shows you 1 millimeter square of growth. On the left, 4.58 millimeters squared of geographic atrophy. On the right, there's 1.15 millimeters squared more growth. You can barely see it, and that's probably why it did not translate into any visual function benefit. It can be measured. It may not be large enough magnitude to have any clinical relevance. Limitation number 3, the anatomic benefit was not associated with any pre-specified secondary outcomes that were for visual benefits. These vision benefits were presumed to develop with time, but there's no evidence that there's any vision benefit over time. For visual acuity, there's a substantial loss in visual acuity. On average, all groups lost 7.5 letters by 2 years. That's about the difference between using laser to treat DME and using anti-VEGF to treat DME. On average, the groups differ by 7.5 letters. The same thing here, there's substantial loss. It's not that you can't measure loss, you can. It's just that that amount of vision loss was the same, regardless of whether the participant was assigned to pegcetacoplan or assigned to sham. This was true not only for best corrected visual acuity, but for other pre-specified vision outcomes: maximum reading speed, functional reading independence index, a well-characterized approved survey to measure how someone might read, or the mean macular sensitivity within specified areas in those participants that had micro. Yes, there are post hoc analyses that in certain groups show that there might be other benefits, but those are generating hypotheses. They weren't the primary or pre-specified secondary outcomes. Finally, the fourth limitation is a safety limitation. There was a much higher rate of developing choroidal neovascularization within 2 years in the groups given pegcetacoplan either monthly or every other month, compared to the 4% event rate of developing choroidal neovascularization in the sham group. And rarely, this is less than 1 in 1,000, but still, it exists, it's not zero. Participants or patients may develop retinal vasculitis in association with these injections. In fact, 14 of these eyes that were looked at in detail among 13 patients developed substantial occlusive retinal vasculitis with anterior chamber inflammation, with permanent visual acuity loss, and some of them even anterior segment neovascularization. So we might ask ourselves, why might a regulatory agency come to 2 opposing conclusions in 2 different continents, despite the public health impact of geographic atrophy from macular degeneration? And this brings us to discussing the benefits and 4 limitations of evidence that we should consider in the management of geographic atrophy, which may start on this fundus photograph with lots of drusen and just a small area of atrophy, which inevitably over the next 10 years will continue to grow and then be associated with some central visual acuity loss. The good news, we have 2 FDA-approved treatments for geographic atrophy in the United States and in some other locales in the world. Primary outcome showed less geographic atrophy growth. That led to approval of the first treatment for this public health problem. However, the maybe not so good news is the magnitude of the anatomic difference is very small. Follow-up was less than 80% at 2 years, which diminishes our confidence even in this anatomic benefit. But most importantly, the anatomic benefits were not associated with any clinically meaningful benefit across visual acuity, low luminance, reading speed. Vision outcomes, again, should not trump. Vision outcomes, again, should trump anatomic outcomes. There were common safety concerns of an increased risk of developing neovascular AMD and rare safety concerns of occlusive vasculitis. Thank you.